Welcome to this video on the loneliness pathogen. We explore how redefining social disconnection in clinical and public health can help us better understand the epidemiology, biological cascades, and the effectiveness of various interventions. It is crucial to distinguish between loneliness and social isolation. While isolation is an objective lack of contact, loneliness is a subjective experience that acts as an independent risk factor for serious outcomes, including suicide attempts. The epidemiology of disconnection is complex. Data shows distinct clusters of risk: the youth spike, the midlife penalty, and challenges faced in the majority world, all of which manifest differently than in stable older populations. Clinical conditions, such as HIV, prostate cancer, and COPD, intersect with social disconnection. We also observe the solo paradox, where neurodivergent individuals may experience both a profound need to belong and a need for solitude. Loneliness exerts a biological toll through the brain-heart axis. Chronic psychosocial stress activates the HPA axis, leading to systemic inflammation, endothelial dysfunction, and accelerated cognitive aging, showing that loneliness is a measurable hazard. We must view loneliness as an exposome hazard that bypasses genetic protections. The clinical imperative is clear: treating depression is not enough. We must actively foster social connection and well-being to halt physical frailty. The intervention landscape is vast. Solutions range from analog, in-person community programs like group arts and micro-volunteering, to digital tech-based tools, all integrated into multimodal care. When it comes to social connection, the structure matters more than the activity. We define a, quote, social dose as consisting of stable cohorts, predictable rituals, shared goals, and psychological safety, which are essential for true impact. Evidence supports the community toolkit, with arts-based social prescribing showing the largest effect sizes. Beyond health benefits, there is a clear financial case, as these programs can reduce emergency hospital admissions. For digital health, we must separate hype from evidence. While VR nature interventions show high potential, commercial AI chatbots often have fragile evidence, and the digital divide remains a significant barrier to equitable scaling. Micro-volunteering and the old help old model demonstrate how agency serves as an antidote to loneliness. These bidirectional interventions provide rapid relief and foster long-term improvements in mental health for both providers and recipients. Non-traditional companionship, such as dog ownership, acts as a precision-targeted emotional buffer. It is independently associated with lower loneliness, though it is not a substitute for broader human social networks. This matrix synthesizes the clinical effectiveness of various modalities. It highlights that while some tools like arts-based prescribing offer high evidence and effectiveness, others like AI chatbots currently show low or no effects. Ultimately, the future of integrated care requires a clinical pathway: screen for loneliness, triage appropriately, and deploy targeted social prescriptions. We must treat social topology with the same precision as biological pathology. This video is not for clinical guidance. It is based on information compiled from scientific abstracts available online and does not cover the entire universe of information available on the subject. We extensively used AI for collating the information, and due diligence was exercised to check and verify the information. However, errors may creep out. The aim is to kickstart a discussion on healthy living and come out with points to discuss with peers and care providers. Please do not take clinical or treatment decisions based on this video.